Welcome to CME on ReachMD. This episode is part of our Minute CE curriculum. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
This is CME on ReachMD, and I'm Dr. Emilie Vander. Here with me today is Dr. Karin Blakemore. Let's talk data. Dr. Blakemore, if we suspect the risk for FNAIT in a subsequent pregnancy is high based on a prior pregnancy, what options can we offer the patient to reduce this risk?
Well, we start with early dating. We want to establish really good dating on the patient. And we want to know what is the father's genotype, the platelet genotype, because if he is homozygous for the antigen that had affected their previous newborn in the previous pregnancy, then we know that the fetus is going to have that antigen and the mother will be making antibodies against that antigen. If the father is heterozygous, because these antigens, say HEPA-1A and 1B, they're codominants, so they're both expressed. But if he's heterozygous, he might pass on the antigen, which is the one the mother has. The baby may end up obviously with her antigen and his non-offending antigen and not be at risk at all. I think this happens for HPA-1 in about 15% of the time, just given the population frequency of heterozygous fathers. So that's the first thing that we'll do. And if the father is heterozygous and might have passed along the offending antigen, but might not have, then we do an amniocentesis and we determine the genotype of the fetus, the platelet genotype, and that will tell us whether or not this pregnancy indeed is at risk. In the meantime, we've usually started our IVIG, which is the mainstay of therapy currently. We start at 1 gram per kilogram per week. We don't add prednisone unless we find a low platelet count later on. Prednisone has its disadvantages as a therapy to the mother for her bones, for her eyes, and while it doesn't cross the placenta, it still has an effect on the mother. And so we start with IVIG at 12 weeks. We do the amniocentesis at 16 weeks if the father was heterozygous, and then continue the IVIG depending on what our amniocentesis results showed. From there, we do serial ultrasounds because in about 20 or 25% of cases, you will find growth restriction or a small for gestational age fetus going along with the NATE in NAIT-affected pregnancies. So we do serial growth ultrasounds. And in addition, we're looking obviously for head bleeds. We certainly look for any bleeds that might show up in the fetus on a fetal ultrasound from there. Some centers like ours will be doing a fetal blood sampling. Usually we use the intrahepatic vein to do the fetal blood samplings. Or cortocentesis to establish what is the fetal platelet count and how are we doing. From there, we decide whether we might want to add prednisone or not if the platelet count was low. Usually it is not, and decide based on a shared decision-making model when we're going to deliver the baby.
That's great. I find the increased risk for fetal growth restriction fascinating. Do you have any thoughts? Is there like a placental issue at play with the FcRn receptor or something that you think is causing this?
I know we did some studies on looking at placentas in the proband pregnancies. Looking at their placentas, we see that in the untreated fetus, we'll see a chronic velitis. It's looks like B lymphocytes within the placental mesenchymal core. They're filled with velitis, and we know velitis goes along with intrauterine growth restriction. We'll see it with CMV, with cytomegalovirus. We'll see a velitis. But what it's doing there in the untreated proband placentas, if you happen to have the placenta to look at, because again, those babies are often born unexpectedly with low platelet counts as the firstborn in the family to be affected. But if you have the placenta, you will see velitis, and that's about the best I can tell you what the relationship might be.
Interesting. There's some sort of inflammatory process going on that's affecting these pregnancies. Well, this was a great but brief discussion. Hopefully, you can put some of these tips into your own practice tomorrow. And thank you again for listening.
You have been listening to CME on ReachMD. This activity is provided by Omnia Education and is part of our Minute CE curriculum. To receive your free CME credit or to download this activity, go to reachmd.com/CME. Thank you for listening.